The topic for our panel discussion is just whose quality of life is it anyway, and to really focus on thinking of this from the patient's perspective. I'd like to let Dr. Nitin lead this. So Dr. Nitin, please go ahead.
Thank you, Komal. And it's been wonderful hearing these talks. And I've learned a lot from this over my own journey over last 2 years. And every time I listen, there's something new which comes up. So without wasting time, let's start with it. And a very apt title, whose quality of life is it anyway? And many times as clinicians, we are more concerned about the outcomes based on the scans. But to be frank, sometimes it's the other aspect. So we'll start with Aisha and Komal, and maybe Aisha can answer this first. That as a caregiver, what factors do you consider important in assessing the quality of life? Is it the physical factors, the psychological, the financial, or the disease status?
Thank you, Dr. Nitin. I think obviously the right answer is all the above because, all of these are extremely important. You don't pay the utility bills, it's going to ground you down in terms of your level of stress. Overall, I think whose quality of life is it anyway should be centered around the word stress. The patient needs as low a stimulus as possible. The caregiver needs as many structured conditions as possible so that you meet needs to keep the stress levels low, right? So you're functional. But already the patient is, generally non-functional. Yasser, for example, has to nap like a cat. We like laugh about it. He'll walk in, he'll say a few words, and then he'll get tired, and then he'll nap, and he'll come back, eat, and then he'll nap, and then he'll come back and read, and then he'll nap. Because there's so much that they're experiencing inside their head that is not even articulated because they probably get tired of talking about how hard it is for them. That everything around has to be just perfect, like Goldilocks perfect for them to just get through life, and life isn't like that. The bills will lapse, and sometimes people will say mean things, sometimes it will be me, sometimes it will be him, sometimes it will be somebody else. And I think the psychological aspect, perhaps if I was to choose one, is also very important, but I do feel that everything eats into everything else. You can't really choose one thread. But if I had to, I would just say, center caregiving, center medical advice, center home and life and well-being around keeping stress to a minimal and keeping routine and structure as a most important priority.
Right. I think from what I understand is caregivers need to be given more attention, and because the patient, of course, is being attended to, and sometimes the focus of the entire families also remains with the patient, but the immediate partner, like the spouse in your case, has to take care of the patient, the family, and the other parts. So I do understand.
Can I just add to that, Dr. Nitin?
Yeah.
So this past year has been really sort of the year where my mental health has been far worse than Yasser's. I think it's acute PTSD, we could say it's a trauma response, we could say it's fatigue. But either way, like I have been aggressively in a mental breakdown state at least about 5 to 7 times in this year. And it's always like, you're not the one with the tumor. What is wrong with you? Right? And I say that it's almost like I gaslight myself. I'm like, I'm not the one with the tumor. What's wrong with me? So I feel really guilty about having this entire, non-functional side to me, which is always in pain, which is always in tears, which is always like breaking down and throwing things and just losing everything, things at the last moment. And I feel like sometimes, there's something called mirror neurons where I feel like when things are normal or okay, that I need to create chaos to feel normal. Like I just, it just, it's like I've come back from a Vietnam War, and I cannot handle normal life anymore.
I understand. I understand. And I think this is where the Brain Tumor Network, wherein they are having volunteers or experts to navigate this entire journey, really is a very good idea. And it need not be physical. I think now technology, pandemic has taught us that even an online availability or over the phone availability would address this. Komal, anything you would like to add on?
Yeah, I just add that, I mean, everything Aisha says is exactly, I'd reflect that. But I'd like to add that I think in my experience as a caregiver, I was just trying to be practical and go with what next, like as pragmatic as possible, not thinking of the emotional side at all. Actually, almost, I think, blocked it out because I felt that if I keep focusing on that, I won't be able to actually support Taha. And for me, at least, I realized that everything came crashing down after the fact. So when I was able to sort of let go and just, what I say, thaw, I guess, because I wasn't in this heightened awareness space, which I was for 3 years. And that time it was all difficult, but I think I didn't let it get to me somehow. I don't know how my body worked or my mind worked, but I think it was after the fact that I needed even more support as a caregiver, at least. But I think, of course, for the patient themselves, as Aisha was mentioning, it's trying to keep them away from all of these, issues of are the bills paid, or is, the doctor's appointment set? What do I have to do next? Keeping the patient's life just perfect, and whatever perfect means in that moment of time. But yeah, I'd just like to add that it's for caregivers, it's a lot of it is after the fact, and how to deal with them and focus on themselves, because they probably haven't had a chance to do that at all.
I think it's very important from talking to both of you is that somewhere the caregivers also need to be addressed. And I think support groups and peer support groups, and this has been our own experience, that the patients, when they meet each other, they exchange numbers, and many times they just keep on talking. The relatives, the caregivers, not the patients. And continuing with this aspect, I would like to ask Dr. Susan, because she runs both the caregiver program and also the survivorship program, that how do you find the balance between the quality of life for the patient and for the caregivers? Because when the patients come to you with a new diagnosis, how do you initiate both the programs? Dr. Susan?
Well, thank you very much. And I also want to thank just the speakers today for their courage and their honesty. These are things that are really hard to speak about. And I think bringing it out in the open and making it real to everybody is so critical. So just to give you a little bit of a history of our caregiver program, it really started from our caregivers reaching out to us saying, I remember one of my patients' wives telling me, that we just didn't do a good job with the caregiving part. And that struck me really hard, because I sort of, try to look at myself as somebody who takes good care of patients. And when she said that to me, I was just like, oh my gosh. And it was just a revelation about, what we were doing with taking care of our patients and missing out on taking care of our caregivers. And so that really jump-started our whole initiative to have this program. And so what we've done is really, again, starting out with the same as the survivorship program, is listening to our caregivers. And you've heard them today about how hard it is, and that their needs can vary depending on the trajectory of the illness. Their needs vary from the patient's needs. And in addition to what you're hearing about how hard it is and how they have to take on so many roles, right? These are roles that they're not familiar with. But there's also that sense of guilt that we've heard from our caregivers, that they're not good enough, that they can't do enough, that, why are they thinking about themselves? They feel like if they do think about themselves, they're being selfish. I mean, there's so many dynamics that go on. And so we sort of stepped back and said, we wanted to meet the caregivers very early on in the illness. So as soon as a patient gets operated on a new diagnosis, our caregiver team, actually our nurse who works with her, is the co-director of the program, she actually meets with the caregivers in the hospital while the patient is recovering from surgery to help introduce them to what to expect. Because I think you've heard that, the timing between the diagnosis for a symptom, a scan, and the decision to have surgery is usually very, very short. And the disruption to the lives of the patients and the families is huge. And everybody's scared, and they don't know what's going to happen next. And so we really felt that by taking the time to meet with the caregiver at that point in time, to even just understand who are all these doctors you're going to be learning about, what are some of the things that are going to happen when you get discharged. You're going to have to be the doctor, the nurse, the pharmacist, the physical therapist, everybody as you take this patient home. And that's very scary. And so we actually have a lot of resources to orient the caregiver as to what to expect. And we have a number of videos, for example, that they can watch in their own time. We have a manual that we've created, an orientation to caregiving that we present to them as well. And then we follow up with them 2 weeks later in our clinic to make sure that the patient and the family understand the resources that are needed. And then we also, for glioblastoma patients, as everybody has pointed out, that's a very unique population. I think Melissa really highlighted that in her talk about having support groups specific for patients with glioblastoma. So we actually do a check-in with those patients and families. We do a caregiver check-in, before they start treatment, after they start treatment, 6 months later. And we really try to be very holistic in our approach. We have a caregiver support group, so it's purely for the caregivers to meet, because a lot of times when we had our patient support groups, of course the caregivers are welcome, but a lot of times the caregivers may not want to say things that they think might hurt the patient themselves. And so we felt that it was important for them to have their space to support each other, to come up with strategies that maybe other people hadn't thought of, the caregivers hadn't thought of, and to be really able to have that sort of community, because the isolation I think people feel is huge. There's a couple of key points that I wanted to bring up about caregiving, specifically is, our neurocognitive care clinic that we established was really focused on the patient. But as you all know, a patient's cognitive and behavioral changes affects the family. And so we now recognize that to care for that patient, we have to care for that family, for them to understand why the patient is having these issues, how to help to de-stress the situation, to make things more structured. I think you've heard that from Komal and Isha about how to sort of structure those things. And then the last thing I would say in terms of the balancing is the children in the home. So a lot of parents one of who may have a tumor and then they have young children in the home, I think the stress of that is particularly hard. You heard it from Isha as well, right? About how to help understand how they are now as parents, because the roles are very different. But then how do you explain to the children what to expect, why their dad or their mom is changed, what's happening, and helping get resources to understand how to navigate having children. I'm very, very excited to hear about Anita's work with Oscar's Angels, because I'm also thinking about how do we take that great experience and help the children of patients with brain tumors. Not that the children themselves are sick, but they're experiencing, right, the journey. So I'd love to hear Anita's perspective on that too, just as another side. Thank you very much again.
Yeah. Yes, Anita. Yes, you are muted. You unmute.
Yeah,
yes.
I actually have a good example, because in Toulouse, for example, our neurosurgery, the reanimation of neurosurgery is mixed. So you have the children and you have the adults. And as we have the experience with the brothers and sisters of the children that we actually care for, and we help them going see the children in the ICU when they are there, the same team takes care of the adults. And so we started a protocol to be able, now it's been going on for at least 10 years, to be able to, with our volunteers' involvement, to prepare the children of the adults they are taken care of in the ICU to go and see them and visit them. And that is extremely important also for when the adults are going to pass away. So there is all this work that has been done, that has years and years of experience, and it's extremely successful, really extremely successful, because the families have the ability to come to us in a different way and have more information, and we have the experience to prepare the children to have that kind of vision they're going to have of their parents or their grandparents.
Wonderful. I think remarkable. And again, I think it's very important for the clinicians who are listening to us, to the neurosurgeons, to the oncologists, neuro-oncologists, that this aspect needs to be addressed. And it's not just taking care of the patient medically, it is the patient and his family. And apart from the medical needs, there are the psychological needs. And in continuation with this, I would like to ask Melissa, because in my own experience, when I try to talk to other centers, to neurosurgeons, to oncologists, many times, and to the hospitals, many times there is a resistance because they don't see an immediate benefit. There is not much of financial benefit. There is not much immediate scales to tell that this is beneficial. So how do you motivate? Because in your talk, you said you have a lot of doctors who help you in various aspects. So what is your message to doctors and to those support groups who want to involve more centers to motivate them or to help such support groups?
Okay. I would like to say that, many doctors, they really have the heart for the patients. I mean, just like yourself, Nitin, you started something in India for your patients, and also Dr. Inam, you are also involved, isn't it? Right? So I think we have to understand the doctor's perspective of their involvement, because firstly, doctors are very busy people. They have to attend to emergencies and they have a lot of things to do. So I think when you present the opportunities to the doctors to be involved, you have to appeal to their heart, but you also have to show sensitivity to what they are concerned about. Like, for example, they'll be concerned about the workload, right? So you have to, like what BTSS does is to not get doctors involved in the running of BTSS. This is a patient function. So we decide the programs, etc., etc. And we are very clear about the doctor's involvement. Like, for example, it's the area of vetting and reviewing resources. Well, they can do that, isn't it? And when you have a panel of doctors, you can, and they're multidisciplinary, you can also divide the work for them. Okay, and you leave it to them to decide how they want to do it. Perhaps they may involve their peers as well. And I really welcome that. And I think also the other thing that the patient organization needs to do is to build your credibility. The doctors have a heart and they like to be involved, but they want to make sure that they are involved with patients, patient leaders who have the commitment and the credibility. So you have to build trust. Like, for example, when I have talks and the doctors are featured, I often remind the patients and caregivers who are attending that this is not a personal consultation session. Now, doctors are really afraid to be stuck there, isn't it? I say, everyone, please be reminded that this is not a personal consultation session. The doctors are here to share their expertise, right? So if you want further questions to be answered about your condition, you have to make an appointment, something like that. So, I make sure that I know about all these. And how do I know about all these? It's because I talk to the medical advisors. In fact, I have like Dr. David Low, he's the vice president of BTSS. So he talks to me very openly
about their constraints. And I share with him very openly also about our expectations. And somehow through our communication, we are able to know how to navigate each other's world, that we can come to some sort of meaningful collaboration. And I think the thing that doctors want to hear is when the patients go back to them, the patients say, BTSS has been a great help to me. Thank you for referring me to BTSS. So patients' organizations have to build credibility to show that we can value add. And when the doctors can see that, they will give you their support.
Right. Wonderful. That's a very good perspective, Melissa. And I mean, continuing with, again, this aspect, I would bring this question to Anita. That, I mean, it's a remarkable. I was very much impressed, and we see our pediatric patients being wheeled in, and from the OT gate, they just start crying, and I can see the gut-wrenching emotions on the mothers and the fathers. How do you motivate your volunteers? It's a tough job. I mean, to get sustained volunteer backup. I tell you, I have been trying to get volunteers. I am requesting caregivers who have successfully treated, their patients are treated, benign tumors, they're back to their life. A lot of medical students, but it's so difficult. So how do you do that? And because a good volunteer is very support is very important for such patient support groups.
Yeah, it is, and I think there is not one answer, to tell you the truth. It is difficult, full stop. I think it is difficult in every country. We never have enough volunteers. That's just reality. I think you just motivate them. You can motivate them in making them feel special, because they are special, and I think, in our cases, they feel it's particular position for us, because our volunteers are real member of the teams, and when they realize that the teams do respect them, and that is the key thing, they are not thought of as outsiders, like unfortunately most volunteers are, but as for the preparation and their expertise, they are really considered 100% members of the team, and they feel like it. And that really makes them very strongly attached to the team and wanted to stay with the charity. So I think you have to teach also the teams to trust volunteers. At the same time, you have to have on the other side a charity, an association that is very serious on training. I cannot stress that enough. You have to have volunteers when they have the kind of positions we have, of course, that are very highly trained. Then everybody's happy because they are trusted and they feel really a part of the group.
I think that's a very valid point, wherein you involve them with the medical team. I think they become responsible and they feel that they are part of something very important. A very valid point. Now I would like to ask Christy, and Christy, I'm really impressed by the navigation, because I can understand that a patient has to go, it's a simple scenario in the hospital from A to B to C place, and it's a struggle for them, and especially in large hospitals. Now, what I want to know is, in your own experience of your organization, what are the most vulnerable points during the entire course for a patient and for a caregiver, and how do you try to address them? Do you preemptively address them, or do you address them as and when it comes?
That's a great question. I think it's a mixture of both. I think we try to preemptively address them, and we do address them as they come up. But, there's not one particular point. I think there's many points along the journey when they're newly diagnosed, when they have a recurrence, when their treatment stops, or maybe they're in between treatments because they feel like they oftentimes don't have control anymore of what's happening, and there's nothing going on. So a lot of times that creates some anxiety. I think when scanxiety, everyone's heard that term. I think when someone's going for their scans, it brings up a lot. Also, when there's tension in the family about different treatment options or long-term care planning. So we really, like I said, we try to do, all of it. Also, when there's a loss of, when patients are very symptomatic and maybe are having trouble communicating, I think that can be difficult for the caregivers, as we've heard before, as well as the patients. So there's many, many times along the journey that I think it can be distressing for patients and caregivers. And we just, and you never know, every patient, every family is different. So you don't know what's going to be the most distressing to that unit until it happens, I would say. So we're just open and here to support as much as we can, when we can, and try to meet the patient where they're at.
Right. And just to follow up with it, how many patients or families does your navigator take care of? Is it one at a time or is it many at a time?
No, we have many at a time. So last year we navigated over 550 families, and every navigator has about, I would say, an active caseload of 50 families that they're navigating at any one time.
Okay, so that's a very significant number because they would be getting random phone calls and very challenging and great. But I think that's a very good idea, and we all can sort of think of having these navigators in our hospitals to begin with. It could be a neuro nurse, it could be a physician assistant, and it really, as you have shown, it really makes things very easy. Yasser, you would like to add anything about these concept of navigation and the vulnerable points, or maybe Anita, you can, Aisha, you can.
Yeah, I think Yasser can take it. He's just had a small nap, so he's good to go.
Okay.
No, I think there's obviously a lot of room. So, for example, let me give you my example. When I came out of the surgery and I was going into radiotherapy, the adjuvant treatment. My expectations were not entirely met by the adjuvant, therapy, or let me say that I felt that I was out of my depth. So that I think was an issue. As far as the navigation is concerned, I think we need to navigate the issues in terms of getting brain tumor patients enough therapy and the kind of help and aid that they need in terms of going through difficult patch. Now, I went through a very difficult patch. I had extreme depression for a very long time, for 4 months or so, and I became slightly suicidal, or I should say, suicidal period. And that was a very hard time for me when I came out of it. There were extraneous factors as well. I don't deny that, but some of it was when I put radiotherapy, radiation, that took me back basically. So overall, those are the kind of issues that I imagine would need to be dealt with for better care in the future.
Dr. Nitin, can I just add? Yeah. So there were two particular times where I thought that the holistic approach was completely missing. One was right before the brain tumor surgery, where Yasser underwent catheterization, which is a normal standard operating procedure before any surgery. Catheterization by any measure for a man is a very painful experience. Now, you have geared up all your willpower for the surgery, right? And for getting under the knife, having your head open while you're awake. But nobody tells you that there is a bump right before it. And so what happens is that when staff just comes in, takes your sense of control away, cuts down, catheterizes you, you're done for it. That's all the willpower you've had for that day. And that sense of loss, that sense of not being in charge, that sense of not just somebody had to just say that right before you go into surgery, it'll be a tiny little pain, so that things like just letting expectations management happen. And the other time, I think, where we were completely both out of our depth was, I think, 2 years into the treatment, I think after the first surgery, when Yasser had, actually after the second surgery, which was during COVID, by the way, and had its own challenges, we had to go through radiotherapy, right? So again, this is like a patient who's had his sense of control taken away over and over again. And radiotherapy was so difficult. And for some reason, we thought that because you had undergone the second surgery, nothing can be harder than that. But we didn't expect that there's something that can knock you off your feet in such an extreme way that he would want to try and kill himself. I mean, I didn't have anything in my toolbox for that. What do you do? Because I just kept thinking he wants to live.
Right. So I think, we can really understand the challenges, and to be frank, it's so difficult for clinicians to look at these aspects because they're not exposed to. And I think we as patient support groups or peer groups really are exposed to such things, and it is very, and I'm grateful for you to highlight these things in front of our clinicians, so that each one of us is sensitized to at least start in small baby steps and think really about having small support groups. Maybe one nurse of yours can be taken as volunteer and just given time and space to talk to the family who is getting admitted. I think time is always a concern, and I'll put my one last important question to Kathy. And Kathy has really been a role model for all of us. She's always so enthusiastic. Kathy, this is fine. We are trying, all of us, in small bits to work out. But when it comes on a bigger scale, say a national level or a state level or a county level, how do you approach the policymakers at each of these levels? Because again, for them, it is setting up a radiation machine, getting a microscope in the department, getting buildings is fair enough. They understand that. But when we talk about other aspects like empowering the patient, sometimes they look at us, what are you talking? What more do you want? So how do you address them in a very positive way? And how do you try to sort of get things done for the benefit of patients on these aspects?
Okay, well, thank you, Nitin. Before I answer your question, may I just add one more quick comment, because I know we're short of time, to the caregiver issue that Komal and Aisha were talking about. As a former caregiver myself to my son, when he was diagnosed, it was like being pushed off a cliff without a parachute. And nobody told me about the existence of support groups and patient advocacy organizations. When I ultimately did find these groups, they really were lifesavers to our family. But there's another, and you develop a kind of routine as you go through the months, the years, however much time you have. In our case, it was 7 years. You develop a routine, the clinical visits, the MRIs, the waiting, the scanxiety, all of that develops into a new normal, a way of life. But there's a second time when, as a caregiver, you are pushed off another cliff. And that is after the fact, as Kamal was describing it. Because when the patient is no longer in your care, you are forgotten about as a caregiver. And I really do think that support groups and healthcare professionals should continue, if they possibly can, to be in touch with caregivers, to make sure they are on the road to recovery, to make sure they are able to function again and resume some kind of life. So I see it as a continual process that doesn't end at a particular stop. It's when the person feels that they can go out into the world, the caregiver feels they can go out in the world again. So I just wanted to make that observation. And turning now to politics and policies and governments, I did say in my presentation that a lot of this boils down to politics and money. We need money to pay for services, to pay healthcare professionals, and we need policies that support healthcare professionals and the delivery of the best possible healthcare services to patients with brain tumors. And there are ways of getting the politicians on side Sometimes you might find a politician who actually has a personal experience of a brain tumor in their family, and they will be very sympathetic and support what you're trying to do. Other times you have to make the first move and be proactive and get these politicians on side. And one way of doing that is to, in the UK, for example, we've established an all-party parliamentary group on brain tumors. And that is a cross-party group. It's not party specific, a cross-party group of MPs, members of parliament, who get together several times a year and are presented with the latest challenges we in the brain tumor community face. Here in the UK, research funding for brain tumors is about 1% of the national spend on cancer research, which is very low. This is a similar case in other countries. So we have tried to explain to politicians how they must change that from the government perspective of providing more funding for more research into brain tumors, because brain tumors have the highest level of life years lost than any other cancer, pretty much. And, you know, we need the amount of spending is not equivalent to the amount of suffering and, you know, difficulties that patients face in the brain tumor world. So here, as I say, we have a UK parliamentary all-party political group. In the US, and Suzanne will know much more about this than I do, but I can just tell you that they have an annual event called Head for the Hill, which again brings the patients into, and the caregivers and healthcare professionals into Washington, D.C. to meet the senators personally, face to face, and tell them what the problems are. Communicating by email and letter is all very well, but it's when you talk to these people face to face that you can really make an impact. And that's, of course, been affected by COVID now. But the Head to the Hill, I think there are hundreds of people that are involved. Am I right, Suzanne, in the activity? It's a really successful one. And just generally in Europe, anywhere, if you can find other organizations outside of your own charity or foundation who are actively participating in policy work, latch onto them, piggyback onto them, and go with them in their campaigns. We do this with an organization called the European Cancer Organization, which is a policy organization working at European Commission level with people representing cancers there. And there are also the European reference networks I mentioned in my talk, where there's a lot of policy involved with that. You have to cultivate this. It's hard work, but it can be done, and that's been demonstrated in other countries. And of course, the patient stories are so important when you do go to see your politicians, because that is what they really want to hear about, the patients, and they want to hear from them as well. And I think that's, I can finally say, if any politician is in doubt about the benefit of what everyone on this group is doing, all they need to do is watch the video of today's presentations. That's the short answer. Show them this video and the benefits that can be had through patient engagement and patient advocacy.
Wonderful. Thank you, Kathy. As you always put it so nicely, and it all reflects the amount of effort you have put and to bring us all together. And with this, I would like to conclude this panel discussion. There are still a lot of questions, but I think it's a never-ending thing, and we can be in touch with each other over WhatsApp, emails. I would once again like to thank all the speakers for their own wonderful insights and sharing their own experiences. And I would like to thank Dr. Inam for organizing this once again, and also Komal for putting so much effort. And finally, Aisha, I would really like to thank you. It's tough as a caregiver. We all we see it daily, but I think you have the mindset to navigate it. And now with being around, maybe there is always further option available for you. So with this, I would like to just make one or two remarks, concluding remarks. And these remarks are more for our audience, our listeners, our clinicians, that as you have gone through these various presentations and also the discussions, the brain tumor support groups should be considered as an important part towards providing a holistic care. And this is an important part, and we should all seriously start thinking about how to incorporate these practices into our practice. And it really helps to navigate the cancer landscape, as we have heard from all of us. And the aim should be to deliver a good timely care, but also to provide the psychological support, which is such an important part. And I would also like to say that this is a new concept in our Asian communities, in our Asian societies, especially because we have the habit of having joint families, larger families. And if you say, sometimes it is just shrugged off, oh, what do you want, what is support group, we are providing you with all the care. So I think it's time to introspect, all of us. There are going to be challenges, there are going to be social challenges, and we come across daily. Many times the caregivers just say, no, we don't want your support, we are good off. But then there is always, for one who says no, there are two who are willing to say yes. So try to incorporate these. And I also feel that this support should be real time, as Christy has mentioned. Navigating the landscape, it should not be an afterthought. We should not send to a support group once the treatment is over. No, it should be right from the time the patient is diagnosed, right from the time the patient comes to your OPD with a scan which shows a tumor. That is the time we need to get them involved. And start with small beginnings. This is what has been shown to us. Take a neuro nurse, take a social worker who is interested, and you'll find one person and give them one small room and just send the relatives, the patients to their room. And I think that's it. The rest thing will just fall in place. So with this, I would like to end this session, wonderful patient-centric session, and Komal, handing over to you.
Great. Thank you so much, Dr. Nitin, for sharing and for summarizing everything so well. Thank you to each and every one of you who participated and came and spoke and shared your stories, your personal stories, and your motivation to join, for actually being so accommodating and responsive when we reached out to you as well. I think I find myself to be lucky, and I'd like to thank Kathy for actually introducing me to a lot of the speakers who spoke today. I find myself to be honored and lucky that you all participated, and actually a North Star for the Brain Tumor Foundation of Pakistan to eventually try to as a vision to try to inculcate a lot of the activities you're doing. So thank you to everyone, and I'd like to wish you a good evening, a good day, good long weekend to everyone in North America as well. Take care.